anemia diagnosis, for leukocyte count, leukocytosis, neutrophils increased, hemoglobin severely decreased, NRBC none, RCW increased, platelet thrombocytosis, megathrombocyte is increased, for reticulocyte count increased, sickling test positive, target cells numerous, ovalocytes and cystocytes few, Howell-Jolly bodies and Pappenheimer bodies numerous in older children and adult, basophilic suppling present in reticulocytes, osmotic fragility so decreased, ESR low, bone marrow biopsy is erythroid hyperplasia. For treatment, we undergo bone marrow transplant. Medications are antibiotics, pain-relieving medication, and hydroxyurea, assessing stroke risk, vaccination to prevent infections, blood transfusions, treating sickle cell complications. For experimental treatment, we do gene therapy, nitric oxide, drugs to boost fetal hemoglobin production. Course and prognosis, the life expectancy of persons with sickle cell anemia is reduced. Some patients, however, can remain without symptoms for years, while others do not survive infancy or early childhood. Nevertheless, with optimal management, patients can now survive beyond the 4th decade. Sickle cell anemia key statements. Sickle cell anemia is a disease in which your body produces abnormally shaped red blood cells. The cells are shaped like a crescent or a sickle. They don't last as long as normal, round red blood cells. This leads to anemia. The sickle cells also get stuck in blood vessels, blocking blood flow. This can cause pain and organ damage. Low oxygen tension promotes RBC sickling, and repeated episodes of sickling damage the cell membrane and decrease the cell's elasticity. Low oxygen tension promotes RBC sickling, and repeated episodes of sickling damage the cell membrane and decrease the cell's elasticity. These cells fail to return to normal shape when normal oxygen tension is restored. As a consequence, these rigid blood cells are unable to deform as they pass through narrow capillaries, leading to vessel occlusion and ischemia. People with sickle cell trait are generally healthy, but those who exercise heavily, such as athletes and those who are exposed to dehydration or altitude extremes, may sometimes experience sickle cell anemia symptoms. Sickle cell carriers produce both HbA and some HbS when they are subjected to significant stresses that reduce the amount of oxygen in the body. The RBCs that contain HbS can sickle. Glucose 6 dehydrogenase phosphate. G6PD, first enzyme of the glucose monophosphate shunt from the embedded Mayer-Hoff pathway, and it catalyzes the reaction to stabilize red blood cells. 6-phosphate dehydrogenase is the first enzyme of the glucose monophosphate shunt from the embedded Mayer-Hoff pathway, and it catalyzes the reaction to stabilize RBCs. An inherited blood disorder in which the body doesn't have enough of the enzyme G6PD, which helps the RBC to function normally. It is fully expressed in the men with a genetic abnormality, while it takes 2 defective X's for females to manifest the deficiency. G6PD occurrence is most common in West Africa, the Mediterranean, the Middle East, and the Southeast Asia. Black people often have a mild deficiency, 10% to 60% of normal activity. Orientals have more severe deficiency, and Mediterraneans has the most severe. For G6PD etiology, G6PD deficiency is an X-linked recessive disorder. Males usually manifest the abnormality, females are the carriers. Lack of the enzyme G6PD means that RBCs can be damaged and destroyed when the person is exposed to some chemicals, including some medications, or during some infections. Take note, glutathione protects the red cells or the hemoglobin from oxidative denaturation. G6PD deficient RBCs cannot generate sufficient NOD-PH to reduce glutathione and thus cannot effectively detoxify the hydrogen peroxide produced upon exposure to oxidative stress. For signs and symptoms of G6PD, we have weakness or fatigue, abdominal pain, nausea or vomiting, intolerance to physical activities, shortness of breath, fever, hemoglobinuria, back pain, jaundice, pallor, dizziness, and intravascular hemolysis. For laboratory findings, in CBC, decreased hemoglobin, moderate to severe, increased reticulocyte count, in peripheral blood film, polychromasia, RBC morphology varies from normal to marked anisocytosis, poikilocytosis, spherocytosis, or cystocytosis depending on severity. Heinz bodies absorbed on supravital stain. Direct antiglobulin test, negative. Indicators of hemolysis, decreased serum haptoglobin, severe. Increased serum indirect bilirubin, increased serum lactate dehydrogenase, hemoglobinemia, hemoglobinuria. G6PD treatment. Avoid exposure to potential sources of oxidant stress, infection, and medication. Avoid eating fava beans in which a sensitivity exists. Exchange transfusion and transfusion during aplastic crisis. G6PD prognosis. The prognosis for a person with G6PD is very good. Most episodes of AHA resolve without treatment but may be severe to warrant a blood transfusion. Favism is dangerous disease and fatalities are common before transfusion services were available. A G6PD deficient individual can still live normally if and only if this individual is not exposed to oxidative agents. The key statements in G6PD. G6PD deficiency is fully expressed in men with a genetic abnormality, while it takes two defective X's for females to manifest the deficiency. GSH is crucial in reducing hydrogen peroxide and oxygen radicals to maintain hemoglobin ion in the reduced state and protect it from oxidative denaturation. G6PD deficiency is an inherited blood disorder characterized by episodes of acute intravascular hemolysis under condition of oxidative stress. A G6PD deficient individual can still live normally if this individual is not exposed to oxidative agents. The activity of all red cell enzymes, including G6PD, is highest in young red cells, reticulocytes particularly, and progressively declines as all cell ages. Pyruvate kinase deficiency is a genetic blood disorder characterized by low levels of an enzyme called pyruvate kinase, which is used by red blood cells. Without pyruvate kinase, RBCs break down too easily, resulting in low levels of these cells. Pyruvate kinase occurrence, so it occurs worldwide, but most cases have been reported in Northern Europe, Japan, and the US. Many cases are found in Amish population of Pennsylvania. The majority cases are found during childhood, but some who are mildly affected by not be detected until late adulthood. For pathophysiology of PKD, although the inheritance is clinically autosomal recessive, most affected individuals are compound heterozygous for two different mutant alleles. It is estimated that approximately 1 in 100 people carry one copy of disease-causing mutation in the PKLR gene. For the pathophysiology of PKD, PKD is inherited in an autosomal recessive fashion, which means that a child must inherit a gene with a disease-causing mutation from both parents to develop the disorder. The gene that causes pyruvate kinase deficiency is called the PKLR gene, that is located on chromosome 1q21. Though the inheritance is clinically autosomal recessive, most affected individuals are compound heterozygous for two different mutant alleles. It is estimated that approximately 1 in 100 people carry one copy of disease-causing mutation in the gene PKLR. Carriers of one non-working PKLR gene usually have moderately reduced levels of pyruvate kinase activity but do not develop clinical symptoms. It is possible that carriers of mutant pyruvate kinase gene may have a protective advantage against malaria in areas where the disease is endemic. For the signs and symptoms, mild to severe normochromic and normocytic anemia, reticulocytosis, symmetrical growth delay, failure to thrive, cholecystiasis, usually after the first decade of life but possibly in childhood, frontal bossing, hyperbilirubinemia in the newborn, ecteric sclera, mild to moderate splenomegaly, upright quadrant tenderness, Murphy sign, chronic leg ulcers for adults. For the laboratory tests, we do CBC, serum bilirubin level study, peripheral blood film exam, genetic testing for mutation in the PK gene, haptoglobin test, OFT, pyruvate kinase enzyme activity. An abnormal spot test result must be confirmed by the quantitative PK assay. For laboratory results, decreased serum haptoglobin level, decreased hemoglobin, increased serum indirect bilirubin level, increased urinary urobilinogen. OFT is to normal, DOT is to negative. Pyruvate kinase enzyme activity is the gold standard for initial testing for PKD. Falsely normal levels are sometimes encountered due to contamination with normal donor cells in transfused patients. Presence of hemolysis. Comparing pyruvate kinase activity to the activity of other cell age-dependent enzymes often provides evidence of PKD. If PK activity is normal while the activity of other age-dependent enzymes is increased, this is very suggestive of PKD. For the treatment of PKD, we undergo blood transfusion, splenectomy, exchange transfusion in newborns, and bone marrow transplant. For prognosis, some people may have few or no symptoms at all. People who have mild to moderate forms of PKD tend to do very well long term. People with more severe forms of the disease are mostly symptomatic during early childhood. Statements of pyruvate kinase deficiency. Pyruvate kinase deficiency is an erythrocyte enzymopathy involving the Embden-Meyerhof pathway of anaerobic glycolysis. The disease results in mild to moderately severe hemolytic anemia. The hemolysis is the result of failure to produce sufficient ATP. The signs and symptoms are those associated with chronic hemolysis including anemia, splenomegaly, jaundice, and gallstones. The PK fluorescence spot test is the recommended screening test for PK deficiency. The blood film shows prickle cells due to the dehydration of RBC.